it's my real pleasure to have Liana with us today. She's been a friend for many years now. We got to be good friends when we were on the same study section and shared cabs to and from the airport, often with Gary Gilkison. So Gary Gilkison, Liana, and I talked about a lot of stuff over a 4-year period, mostly in cabs and bars. So Liana is the Director of Patient-Centered Population Health Research at Berkshire Health Systems. She was a professor at Yale for many years and still continues to be an adjunct professor there. The program she's leading is focused on improving health population outcomes in predominantly rural region, which we were talking about, and she's hoping for snow because that's great for a rural region to have fun. She's really one of the best, most outstanding health services researchers in rheumatology in the country and the world. She's really helped in an area that not a lot of people have gone into, and she has done really amazing things with patient decision-making, methods to improve quality of the decision-making. She's worked with business marketing people and all types of different fields to really advance our understanding of how people make decisions and how we can help them to make the best decisions. She's been the recipient of numerous awards, including the ACR's most prestigious award for young investigators, the Henry Kunkel Award that she was given several years ago. She, as I said, it's really interesting to look at her career because she doesn't do just rheumatology. She really is focused on many, many different areas, but on the same theme of decision-making and quality. She's also done clinical trials. She's published almost 200 papers. Her training was in McGill, where she went to medical school, did her residency and was chief resident there. She's been also very involved in the VA and had awards there. She's really a great example of someone who has ascended through the K pathway. She got her K23, she's gotten R01s after that, and then has gotten a K24, which allowed her to have time for mentoring. And she's been chief of director of many activities at the ACR, extremely involved in the ACR, was chair of the Quality Measures Committee, just is the first author on the treatment guidelines for RA, which will come out soon. And I'm really happy that she is the vice president of the Rheumatology Research Foundation. So Liana, it's really a great pleasure to have you with us today, and we look forward to your talk on risk communication and decision-making in RA.
Thank you, Lou, for that somewhat accurate introduction and extremely generous as always. So I'm excited to chat with you all. Unfortunately, it's a little bit less interactive than I would like. So I'm not sure how well I'll be able to see the chat. So please just chime in. If you have questions as we go, unmute yourself if you're allowed and chime in with questions. Would be a pleasure to have a discussion as we go along. So I have no disclosures. So let's start off with the rationale for having this talk, which is really a big gap in care that we have in our field, which is the lower than expected rates of treat to target. So we know that the guidelines recommend a treat to target approach, and all guidelines do, both here and across the ocean. That's especially true for patients who are biologic and JAK inhibitor naive. You know, when we're making grandiose statements, we should remember what the data actually show. And the data really are strongest for patients who have not done well enough on methotrexate. After that, it's less clear. But even for that population, we know now from several studies that implementation rates are really low. And in most studies, it's really less than 50% in patients who should have care escalated. So less than 50% in patients with moderate to high disease activity. We're not including here patients with low disease activity. So why is this? So if we're gonna tackle a problem, we really have to take a step back and figure out what are the major causes of this problem. Let's do a root cause analysis. So one issue that we know about is there's patient comorbidities, there are medication lags. You know, we start a medication and we're not going to change a medication within the next couple of weeks. There are significant limitations of our disease activity measures. So while they've been well validated, we know that some of them are heavily weighted by patient-reported outcome measures that may be due to non-inflammatory causes of pain and other symptoms. So the fix for this is really to adjust our quality measure, right? So because of these things, we say, okay, we know that not everybody who's going to have a CDAI of 15 should have their care escalated. So we're not going to expect treat to target in 100% of patients. We should adjust that criterion downward. That's what we mean by adjusting the quality measure. So even if we take into account all these things, okay, let's say it's somewhere above 80%, 85%. People throw around different numbers. We don't have an exact criterion, but we know it shouldn't be 100% for these reasons. Other problems. So unfortunately, in this country, we have inadequate access, and there are multiple reasons. I probably put the two biggest ones here, which are insurance, which is just the bane of everybody's existence in this room, I think, workforce shortages. There are unfortunately really multiple very real barriers to access to care, even in the United States. And the fix for this really is policy, and the ACR and many other organizations are continuing to work very hard at this. But despite those things, which are really not necessarily in our immediate control, one of the most common barriers to escalating care in every paper that has looked at this is what they call patient preference. I would reword this to say it's not really a patient preference, it's really patient hesitancy, which we're now all very familiar with that word because of vaccine hesitancy, and reluctance. And the fix for that is to change patient decision-making. So because we know that in certain patients, treat to target really results in better outcomes, we want, in this case, really nudge our patients to be more willing to adopt treat to target approach.